Welcome back to the deep dive. Today we're embarking on a really fascinating expedition right into the core of what happens when your body moves.
Indeed.
You've provided us with a fantastic set of sources on exercise physiology and exercise science, governmental health sites, professional resources like ortho bullets, a real wealth of information.
Yes, quite comprehensive.
And our mission today is to unpack that incredible symphony of systems that activate, that adapt the moment you decide to take a step or, push through a workout.
Exactly. It's all about appreciating this intricate dance between cells, organs, hormones during physical activity. It's much more than just getting fit.
Right.
It's understanding these profound biological mechanisms that keep us in balance, allow us to
Yeah.
adapt, grow, heal.
It's amazing how simple actions reveal such complexity.
It really is. Seemingly simple things unveil layers upon layers of biological interaction, all highly coordinated.
So let's start unpacking that, the foundational science. The body at rest versus the body in motion. It's a massive shift in energy demand, isn't it?
Oh, absolutely monumental. At rest, your autonomic nervous system, it leans towards a parasympathetic tone.
The rest and digest mode.
Precisely. Keeping things calm, lower heart rate, slower breathing, conserving energy. But the moment you start exercising, even just getting up,
Instantly.
instantly, the sympathetic nervous system takes over. It's an integrated response, really, designed to maintain homeostasis, that internal stability.
To meet that sudden energy demand.
Exactly, that increased demand in cellular metabolism. The body orchestrates this rapid shift through a whole cascade of changes. Heart rate up, contraction force up, blood vessels shifting.
It's like an internal alert system fires off.
Hooked on. Activity commencing, prepare for action is basically the message.
It's remarkable, that speed. But beyond just the mechanics, why does understanding this actually matter to us, to the listener? The sources highlight some really sobering statistics about inactivity.
Yes, and that's the critical link to the bigger picture, the public health angle. The statistics are stark. Cardiovascular disease, for example, is a huge concern.
Still a major killer.
Absolutely. And factors like high cholesterol, hypertension, diabetes, obesity, smoking, they account for nearly half of all mortality.
Wow.
And here's the key point. Lack of exercise demonstrably worsens these risk factors. Inactivity is directly linked to more obesity, type 2 diabetes, hypertension.
It's a multiplier effect.
It really is. Conversely, the evidence is just overwhelming that daily exercise reduces overall mortality rates.
So it actively protects you.
Definitely. Research consistently shows exercise, alongside lifestyle changes, can cut hypertension risk, even if you're genetically predisposed.
Regardless of genetics, that's powerful.
It is. And for diabetes management, exercise significantly boosts insulin sensitivity. Your body just gets much better at using insulin.
Meaning less insulin is needed, potentially.
Exactly. This isn't just, a nice idea. It's a potent, non-invasive intervention. It genuinely improves quality of life, extends healthy lifespan. Movement is fundamental.
A really crucial reminder. So let's get down to the nitty-gritty. Movement starts at the muscle, right? What's happening at that cellular level inside those tiny sarcomeres?
Ah, yes, this is where it gets really interesting. The sarcomere.
Mm-hmm.
It's the fundamental unit of skeletal muscle, the engine for contraction.
A microscopic engine.
Precisely. Finely tuned. It's made of thick filaments, mostly myosin,
Myosin.
which has these little heads that interact with actin, and it uses ATP, our energy currency.
Right, ATP powers it.
And then you have the thin filaments, mainly actin monomers, in the helical structure.
So actin and myosin are the core players, but there are regulators involved too, and calcium. Calcium's the key, isn't it?
You're absolutely right. It's not just actin and myosin bumping into each other. There are crucial regulatory proteins, tropomyosin.
Tropomyosin.
It's a two-stranded protein lying along the actin, sort of shielding the binding sites where myosin wants to attach.
Like a guard.
Exactly. And sitting on tropomyosin is the troponin complex, with three parts, TNC, TNI, and TNT. Each has a specific job. And yes, calcium is the absolute star. When a nerve signal arrives,
From the brain.
it triggers a rapid release of calcium from storage, the sarcoplasmic reticulum within the muscle cell.
Flood of calcium.
A sudden surge, yes. And that's the immediate trigger. Calcium binds specifically to the TNC subunit of troponin.
To TNC.
This binding causes a conformational change, a shapeshift, in TNC,
Right.
which then ripples through TNT and pulls tropomyosin away from the actin binding sites.
Ah, so calcium binding to TNC is like flicking a switch that moves the guard tropomyosin out of the way.
Precisely. The gatekeeper analogy is perfect. Calcium is the key. Once those gates are open, the myofilament actin and myosin is activated.
Myosin can now grab onto actin.
Exactly. The myosin heads bind to the exposed actin sites, initiating force generation. Then, for relaxation,
How does it stop?
ATP-driven pumps actively pump the calcium back into the sarcoplasmic reticulum, out of the main cell fluid.
So energy is needed to relax too.
Yes. Removing the calcium allows tropomyosin to slide back, reshielding the actin sites. Myosin lets go, and the muscle relaxes.
It all resets.
And this whole process, the shortening and lengthening, is explained by the sliding filament theory. The actin and myosin filaments literally slide past each other.
Like telescoping rods.
Exactly. It's a remarkable piece of cellular machinery, incredibly efficient, incredibly powerful.
It really is mind-blowing, that microscopic dance creating large-scale movement. But stepping back from the single cell, what about the bigger picture? The organ systems working together, musculoskeletal, cardiovascular, respiratory, endocrine, even skin and immune systems. Let's start with muscles and bones. How do they adapt over time?
Well, the adaptation is highly specialized, demonstrating incredible plasticity. Let's look at muscular adaptations. Muscle fibers themselves are adaptable. We classify them.
Like type I, type 2.
Exactly. Based on their myosin heavy chain isoforms, how fast they contract, or their oxidative capacity, how they produce energy and resist fatigue.
And this matters for performance.
Profoundly. Type I fibers, the slow twitch ones, are fatigue resistant. Packed with mitochondria, lots of myoglobin, great blood supply.
Built for endurance.
Precisely. Low force, sustained activity. Think posture muscles.
Right.
Then type Phi fibers. Fast, oxidative glycolytic. They're a sort of hybrid.
Best of both worlds.
Kind of.
Yeah.
Faster contractions than type I. Good oxidative and glycolytic capacity.
Yeah.
Less fatigue resistant than type I, but good for sustained power, like lifting for reps.
Okay.
Finally, type I fibers, the fast glycolytic ones. Highest contraction speed, massive force, but they fatigue very quickly. Low oxidative, high glycolytic.
Sprinting muscles?
Exactly. Short bursts, maximum power. But what's truly fascinating, and the sources highlight this, is that these fibers aren't fixed.
They can change.
Yes, there are hybrid types, and fibers can actually transition between isoforms depending on the training. High load, slow speed training, like heavy lifting, can shift type I's towards the more enduring type 3, while high speed power training can shift things towards the faster IBIPF phenotypes.
So your training literally reshapes your muscle cell types.
At a fundamental level, yes.
Yeah.
It's not just making them stronger, it's changing their metabolic machinery.
That is astonishing. So what about muscle growth itself, hypertrophy, and the repair process? And how do bones fit in?
Right, muscle growth and repair. Exercise inevitably causes micro tears in muscle fibers. This isn't damage in a bad way, it's the stimulus.
It's a trigger for growth.
Exactly. The body responds with hypertrophy, increasing the cross-sectional area of the fibers. And satellite cells are crucial here.
Muscle stem cells.
Essentially, yes. They sit on the edge of the muscle fiber. When there's microtrauma, they activate, multiply, and fuse with the damaged fiber, helping it repair and grow larger. They're vital for hypertrophy and healing.
So repair leads to growth, and bones, often seen as static.
Far from it. Skeletal adaptations are key. Bones are dynamic, constantly undergoing remodeling in response to mechanical stress.
Like Wolff's Law.
Precisely. Load the bone, and it responds by increasing mineral density and strength. This is critical during childhood and adolescence for building peak bone mass.
Preventing osteoporosis later.
Exactly. But the benefits continue into adulthood. Consistent exercise helps maintain bone density throughout life. Use it or lose it, really.
Incredible adaptability. Now, let's turn to the heart and lungs, the immediate responders when we exercise. How do they cope with that huge increase in demand?
It's a remarkable feat. The cardiovascular system responds directly and dramatically. The main thing is increasing cardiac output.
Heart rate times stroke volume.
Correct. As workload increases, cardiac output rises to deliver more oxygenated blood to active muscles. But it's also about distribution.
Shunting blood.
Yes, blood flow is strategically redirected away from less critical systems like the gut and kidneys towards the working muscles. Selective vasodilation and constriction,
Like a traffic controller.
a very efficient one. And local factors, like nitric oxide released by blood vessel linings, fine-tune flow right where it's needed most.
And over time, training actually changes the heart itself, makes it stronger.
Absolutely. Aerobic training leads to significant adaptations. Cardiac enlargement, athlete's heart, but healthy enlargement. In hand contractility, the muscle pumps harder, and increased total blood volume.
So it pumps more blood with each beat.
Exactly. Increased stroke volume, meaning the heart can deliver the same amount of oxygen with fewer beats. It becomes much more efficient.
And the red blood cells, they adapt too.
They do. During exercise, factors like increased temperature, lower pH, higher CO2, the Bohr effect, make them release oxygen more readily to tissues.
Clever.
And interestingly, older, less flexible red blood cells can actually break down, hemolyze, when squeezed through capillaries and active muscles.
Really?
Yes, and this stimulates the production of new, younger, more efficient red blood cells, partly driven by increased erythropoietin. The whole system optimizes for oxygen delivery.
Astonishing refinement. You also mentioned plasma volume expansion.
Ah, yes, hypervolemia. Acute endurance exercise leads to an increase in plasma volume. It can happen quickly, peak a couple of days after a long race, and last for weeks.
What causes that?
Hormones like aldosterone and vasopressin play a role, plus changes in plasma proteins. This expanded volume is great for performance.
How so?
It improves muscle blood flow, boosts stroke volume and cardiac output. And crucially, it helps with temperature regulation by increasing blood flow to the skin for cooling.
A performance enhancer and a coolant.
In essence, yes, though it can temporarily lower hematocrit, which needs careful interpretation distinguishing it from true anemia.
Right, so the cardiovascular system delivers. The respiratory system must be the crucial exchange point, working in sync. How does it ramp up?
It's perfectly synchronized. The respiratory system increases pulmonary ventilation air movement immediately, even before you feel breathless.
Wow.
Signals from the motor cortex in your brain, you're just thinking about moving, and from proprioceptors in your moving muscles and joints tell the brainstem's respiratory centers to get going.
Anticipatory.
Very much so. Then, as exercise continues, rising CO2 levels, hydrogen ions, and body temperature provide further stimulus to breathe deeper and faster.
How much can ventilation increase?
Dramatically. From maybe 10 liters per minute at rest to over 100 liters per minute during intense exercise in adults.
Wow.
And the lungs become more efficient too. The available surface area for gas exchange in the pulmonary circuit increases, reducing wasted ventilation, ensuring efficient CO2 removal and O2 uptake.
So not just breathing faster, but better quality breaths too. And managing the waste CO2.
Yes, CO2 is carried away mainly as bicarbonate ions in the blood, thanks to the enzyme carbonic anhydrase in red blood cells. This also helps buffer blood pH.
Keeping the blood from getting too acidic.
Exactly. In the lungs, the reverse reaction happens. CO2 is reformed and exhaled. It's a continuous balancing act.
The body truly is a self-optimizing machine. But what about the hidden players? Hormones, the immune system, they seem just as vital.
Absolutely. The endocrine system acts as the chemical messenger service, orchestrating growth, repair, and energy regulation.
So the anabolic hormones, like testosterone.
Yes, anabolic hormones build tissue. Testosterone stimulates muscle protein synthesis and hypertrophy, especially after resistance training. Growth hormone from the pituitary enhances bone and tissue growth.
And IGFs.
Insulin-like growth factors, IGFs, are crucial. Stimulated by growth hormone or mechanical loading, they activate those satellite cells for muscle repair and growth. They also stimulate protein synthesis directly, very important for adaptation.
The body's natural construction crew. But cortisol, often seen as purely a stress hormone, does it have a role here?
An excellent point. Glucocorticoids, mainly cortisol, do increase during exercise, but play vital roles. Cortisol helps regulate blood sugar.
How?
It stimulates glucose production in the liver while limiting uptake by muscles and fat, ensuring fuel is available for immediate use. It also boosts fat breakdown for energy.
So it manages fuel supply.
And it helps counteract inflammation and maintain vascular integrity. So despite the stress label, it's key for fuel management and recovery. Plus, its levels follow a natural daily rhythm.
Fascinating. Even stress hormones are part of the solution here. And catecholamines, adrenaline.
Precisely. Catecholamines like epinephrine, adrenaline, and norepinephrine surge during maximal exercise. They ramp up the sympathetic nervous system, increasing heart rate, cardiac output, blood flow to the heart itself, the turbo boost.
Got it. And insulin. Exercise impacts that too.
Hugely. Long-term exercise significantly increases insulin sensitivity. Less insulin is needed for the same effect on glucose uptake.
That's key for metabolic health.
Critical. Moderate exercise activates something called AMPK in contracting muscles. Think of it as an energy sensor.
Okay.
AMPK activation directly increases glucose uptake by muscles, moving GLUT4 transporters to the cell surface. And remarkably, this happens independently of insulin.
So muscles can take up glucose even if insulin isn't working well.
Exactly, and this effect can last for hours after exercise. It's a major reason exercise is so beneficial for managing type 2 diabetes.
That is ingenious. And the skin, more than just sweating.
Yes. Exercise training improves the microvascular function in the skin. The tiny blood vessels become better at dilating,
Me.
meaning you can increase skin blood flow more effectively at lower core temperatures. Better heat dissipation, allowing you to exercise harder or longer before overheating. A subtle but powerful adaptation.
Right. And finally, the immune system. How does exercise affect that?
It's nuanced. The immune system response depends on the intensity and duration. Moderate exercise generally enhances immunity.
How?
It causes transient increases in anti-inflammatory cytokines, like IL-6, and a temporary boost in white blood cells, like a daily tune-up for the immune system.
That's great news. But pushing too hard.
That's the flip side. Heavy, prolonged exercise like a marathon can cause transient immune dysfunction.
Making you more susceptible to illness.
For a period afterwards, yes. Often seen as increased risk of upper respiratory infections in the weeks following major exertion. Things like lower salivary IgA, reduced natural killer cell activity occur.
So there's a sweet spot.
Exactly. It raises that important question. How do we optimize training to get the immune benefits without the suppression? It's about managing load and recovery.
Finding that balance. Okay, so all this adaptation, all this complex chemistry needs fuel. How does the body generate the ATP, the energy currency, especially for different types of effort? Burst versus endurance.
Spot on. It uses different systems. There are two main pathways for ATP production. First, substrate-level phosphorylation, which is anaerobic.
No oxygen needed.
Correct. This uses ATP already stored in muscle and creatine phosphate, ATPCP. It's incredibly fast, powering explosive, short activities, maybe a few seconds.
Like a single jump or sprint start.
Exactly. High rate of ATP production, meaning high power, but very small capacity. The stores run out quickly.
So that's the instant power source. What about longer efforts?
For that, the body shifts to oxidative phosphorylation, aerobic metabolism. This happens in the mitochondria.
Using oxygen.
Yes. It's much slower at producing ATP, but vastly more efficient in terms of total yield. It uses carbohydrates and fatty acids as fuel.
For activities like jogging or cycling.
Precisely. Low intensity uses a mix of carbs and fats. While anaerobic pathways give you instant power, aerobic metabolism, especially fat oxidation, provides a huge energy reserve.
Which is why hitting the wall happens.
Often, yes. That's typically when readily available carbohydrate stores, glycogen, deplete, forcing the body to rely more heavily on slower-burning fat oxidation. Power output drops significantly.
Makes sense. So how do we measure all this physiological activity? The sources mention exercise capacity and VO2 max.
Right. Exercise capacity is a really powerful clinical indicator. It predicts overall health and mortality risk.
How is it assessed?
Informally, a doctor might ask how many flights of stairs you can climb or blocks you can walk, but objectively, supervised exercise tests are used.
Like treadmill tests.
Yes. And VO2 max is the gold standard measure of aerobic fitness at peak effort. It's the maximum rate your body can take up and use oxygen during intense exercise.
How's it measured?
You exercise to exhaustion, usually on a treadmill or bike, while breathing into a mask that measures the oxygen you consume and carbon dioxide you produce.
So it measures your aerobic engine's maximum output.
Exactly. It's calculated from cardiac output and how much oxygen your muscles extract from the blood. VO2 max improves significantly with training better oxygen delivery via higher cardiac output and more capillaries.
Can everyone reach their VO2 max in a test?
Healthy individuals usually can, but people with certain conditions, heart failure, COPD, some myopathies, might be limited by symptoms before reaching their true max.
So what's used then?
The 6-minute walk test is a common, standardized alternative for assessing functional capacity in those cases. Any limiting symptoms during these tests, breathlessness, chest pain, palpitations, or red flags.
Key diagnostic tools then. But what about when things go wrong? Exercise intolerance, pain, injury, the pathophysiology.
Yes, understanding pathophysiology is crucial. Exercise intolerance. Healthy people stop from general fatigue or effort-related breathlessness. But those with heart or lung conditions often stop prematurely due to severe breathlessness, usually with an abnormal VO2 max.
What limits them specifically?
In lung diseases like COPD or ILD, it's often impaired gas exchange. Another issue is exercise-induced bronchoconstriction, sometimes mistaken for asthma, causing wheezing and breathing difficulty during or after exercise. diagnosed by lung function tests showing a drop in FEV1,
And cardiac issue.
cardiac strain. In heart failure or coronary artery disease, exercise increases the heart's workload. This gets worse in heat and humidity.
Why the heat?
The body dilates blood vessels to cool down, but this forces the heart rate up further to maintain blood pressure, potentially causing ischemia, insufficient blood flow to the heart muscle itself.
Dangerous. What about muscle problems?
Muscle dysfunction. Myopathies can cause intolerance, often presenting as cramping or pain. Biopsy or genetic testing might be needed. Sometimes, though, intolerance might seem like poor effort, but checking lactate levels can help differentiate true physiological limits.
And simple deconditioning or aging.
Deconditioning and aging. Inactivity leads to muscle atrophy and deconditioning. Hospital patients need physical therapy to combat this. And crucially, increasing exercise intensity too quickly can cause strains, tears, stress fractures. Adaptation takes time.
And aging itself.
VO2 max naturally declines, maybe 10% per decade after 30, due to things like heart stiffening, lower max heart rate, weaker respiratory muscles, sarcopenia, age-related muscle loss.
So decline is inevitable.
Some decline, yes. But, and this is key, consistent endurance training can still improve VO2 max even at older ages. The body remains adaptable throughout life. Exercise profoundly mitigates that decline.
That adaptability is really encouraging. It's never too late. Now, beyond the internal workings, the sources cover the science of how we train, muscle injuries, recovery. Let's start with training types and contractions. It's more complex than just lifting, isn't it?
Oh, much more. Exercise science covers biomechanics, physiology, psychology. Understanding the types of contractions movements is fundamental for specific training effects. Isotonic, constant force, like dumbbell curls. Good for motor performance.
Okay.
Isometric, constant muscle length. Tension matches load. Pushing a wall, holding a plank, builds strength, causes hypertrophy.
Right.
Concentric, muscle shortens under tension. The lifting phase of a curl.
And eccentric.
Eccentric, muscle lengthens under tension. The lowering phase. Often cited as most efficient for strengthening, causes more microtrauma, signals growth. The negative part.
Important for games.
Very. Isokinetic, constant velocity, variable resistance, often uses machines, good for rehab assessment.
Okay.
Plyometric, rapid stretch, shorten cycle. Eccentric, then concentric. Box jumps, builds explosive power.
Spring-like act.
Exactly. Open chain, distal end moves freely. Leg extensions, closed chain. Distal end fixed. Squats, often more functional.
A whole vocabulary of movement.
Yeah.
And tying this back to energy systems, anaerobic versus aerobic.
Yes, that distinction dictates intensity and duration. Anaerobic, glycolytic, uses ATP-CP for 10 seconds max power, or lactic acid system for 2-3 minutes high intensity. Uses fast twitch, type 2 fibers. Low total ATP yield leads to lactic acidosis. Your sprint system,
Right.
aerobic, oxidative, uses glycogen and fats. Uses slow twitch, type I, fibers mainly.
Yeah.
High ATP yield needs oxygen. Your endurance engine.
So training targets these differently. What about specific training concepts?
Key training specifics include periodization, planned variation in intensity duration over time, prevents overtraining, optimizes adaptation.
Cycling training stress.
Yes, dynamic exercise improves cardiac output mainly by increasing stroke volume. Endurance aerobic training changes circulation and muscle metabolism, more mitochondria, better fat burning, conserves glycogen, increases oxidative capacity of all fiber types.
Making muscles more efficient overall.
Exactly. We talk about the aerobic threshold, where anaerobic contribution becomes significant, and the anaerobic lactate threshold, where lactate production outpaces removal. Key markers for endurance.
Important thresholds for training intensity and strength training specifically.
Strength training. High load, low reps. Increases muscle cross-sectional area hypertrophy. Also improves motor unit recruitment and coordination. In adolescence, gains are more neuromuscular initially, less hypertrophy, and reversible.
So consistency is key, especially for young people. What about aquatic training?
Codotic training. Great for reducing joint stress due to buoyancy, less impact. Offers unique cardiorespiratory benefits, less abrupt heart rate changes, higher O2 consumption for perceived effort. Good for rehab and preventing lower limb injuries.
A gentler way to train or recover. Now, some specific exercise-induced conditions mentioned, and then, critically, nutrition and injury management.
Yes, some specific conditions are worth noting. Exercise-induced laryngeal obstruction, EIRLO, often mistaken for asthma, more common in females. Wheezing, shortness of breath. Diagnosis needs laryngoscopy during exercise to see the obstruction. Treatment often involves breathing retraining.
Tricky diagnosis.
It can be. Exercise-induced hematuria, blood in urine after exercise, can be microscopic or visible, linked to intensity, posture, heat, likely due to minor bladder kidney trauma or vascular spasm. Usually resolves on its own, but needs checking if persistent or in older individuals.
Right. Now, fueling that engine nutritional training.
Vital. Carbohydrate loading. Increasing carbs, reducing activity 3 days before long events over 90 minutes. Maximizes muscle glycogen stores for endurance. The classic marathon prep.
Herb loading.
Yes, fluid loading replacement. Crucial for temperature and heart rate. Best practice is replacing enough fluid to maintain pre-exercise weight. For fluid carbohydrate electrolyte replacement, low osmolarity drinks, 10% carbs electrolytes, often with glucose polymers, absorb best without gut issues.
Like sports drinks.
Exactly, the well-formulated ones. Now, muscle injury, muscle soreness, DOMS. Delayed onset, peaks 24-72 hours post-exercise, caused by inflammation, edema, and connective tissue, especially after unaccustomed eccentric exercise. Elevated CK levels possible? It's an adaptation signal.
Growing pains, essentially.
In a way, muscle strain. Tear, often at the muscle tendon junction, usually during eccentric contraction, heals with scar tissue, fibrosis.
Okay.
Muscle contusion, bruise from blunt impact. Hematoma, inflammation, heals with scar tissue, can sometimes lead to myositis ossificans, bone forming in the muscle.
Bone in muscle. Wow.
Yes, usually visible weeks later. Muscle laceration, complete tear, often near the junction, heals with dense scar tissue. Regeneration is unpredictable.
Serious injury. What about immobilization after injury?
Muscle immobilization causes rapid atrophy, muscle wasting, especially early on. Loss of contractile proteins, fatty infiltration. Muscle becomes weaker, fatigues easier. Atrophy is worse if the muscle is held slack. Highlights why early movement in rehab is key.
Use it or lose it again. And treatments.
Treatment modalities aim to reduce inflammation, improve blood flow, tissue compliance, include cryoheat, massage, ultrasound, electrical stimulation, and iontophoresis, using mild electrical current to drive medication, steroids, anesthetics through the skin into deep tissues. Targeted delivery for various conditions, but contraindicated with pacemakers or drug allergies.
Targeted drug delivery. Okay. So, wrapping this all up, this deep dive really shows the incredible complexity and adaptability of the body in motion. From sliding filaments to coordinated organ systems, every movement is a feat of biological engineering.
It truly is. And understanding this isn't just academic. Clinically, recognizing impaired exercise tolerance is vital for diagnosing underlying disease. Exercise testing guides treatment, monitors progress, improves quality of life.
It underscores that movement is fundamental.
Absolutely. Our bodies are designed to move. It's a pillar of health, influencing everything from cellular repair to immunity to mental sharpness. A prescription for life, really.
So the next time you feel that post-workout soreness or push yourself a bit further, perhaps appreciate those microscopic marvels and the systemic symphony working within you. It's a constant process of adaptation. For you listening, what stands out most about this incredible capacity to adapt and heal through movement? Reflect on your own relationship with exercise, those subtle shifts always happening. And if you found this deep dive valuable, please do consider rating and sharing the show. It really helps others discover it.
And it leaves us with a final thought, doesn't it? Given this extraordinary capacity for adaptation, this intricate physiological response, how can a deeper, more precise understanding empower each of us to truly optimize our own health journeys, regardless of our age or starting point, and translate this knowledge into more effective, personalized strategies for lifelong wellness and resilience? The science offers the tools. The application is up to us.